Welcome. Who am I? My mountain is Hekororoa. My awa is the Waikawaiti River. My land is that at Karatani, and my marae is Puketaraki marae and Otaka marae. Tui tuia, tui rongo, tui raro, tui waho, tui roto, tui te here tangata karanga te ao, karanga te poa, ki te whai ao, ki te ao marama, whanau, hara mai te toki, haumi e hui e taiki e. This whakatauki is about joining communities together. It's about inherently weaving a patchwork of values and infrastructure, maybe might be an appropriate word, in our community. Tuarua, he mihi ki ngā tini aitua tēnei wā. Rātou kua whirangi tia o ia whānau, moi oke ai ka mai rā kati rā. In the pantheon of te ao Māori, we also pay respect to those who have passed. We look backwards to go forward in the hope that we remember mistakes made and don't make them again. He tēnei wā, he mihi ki te rakatira of the Southern Partnership Group, ki a koe he te rakatira, tēnā koe. Huri no koutou o te manatu hau ora. To anyone from the Ministry of Health here tonight, welcome. Kia mātou ka mihi nara, Kathy, mihi atu. Huri no ki te tumuaki o te Southern DHB, Chris, mihi atu kia koe hoki. Me te hapori katoa, kua tai mai kia whakaronga ki te taki, ki te kaupapa, kia whakamārama ai, ki tēnei taki, and to all the community who have come together to listen, to be updated and to hear about the work that is going on. Nō reira, ko tēnei te mihi o te mana whenua tēnei rohi, pōtai. So this is our welcome on behalf of, in support of this event, from mana whenua o Otako and Puketaraki. Nō reira, tēnā koutou, tēnā koutou katoa. Kia ora. He karakia te mātatanga. E te aka rā, korore kia te auranga, te timatanga, me te whakaonga me katoa nānane, me katoa te reo mārama. E te atua, homai ke mātou tō ihi tu ihu ka, kia whaiaki nei, he kaupapa tika mō tātou nei hāpori āmene. Kia ora tātou.
E honore,
e gloria, maunga rongo ki te whenua, whakaoro, pai e, ki ngā tangata katoa, ake, Amene, te atua, te whiringa, tōku oranga, Anō reira, rauda ki te rama. Mihi hoki ngā member o te paremata i konei, te rākoe. Mihi mai. Tēnā tātou katoa. Thank you.
Tēnā koe, Marapura. Thank you for that, pōwhiri. And come on in. Tēnā korua. Thank you for the karakia. Just come on in up to the front, folks. No troubles. My name's Pete Hodgson, and we are going to loosen you up with just 3 opening remarks from myself and Chris and Kathy. Before I do, I would like to acknowledge the passing of Tahu Poriki. It's a couple of months ago now, but it's the first time we've had a public meeting since that passing, and he's been a big player in our planning and thinking so far, and continues to influence our thinking, especially in the area of workforce development, something in which he had a passion. He's left a big hole, and some of us are feeling it quite a bit. A little strangely, I'd like to acknowledge the passing of a guy called David Lockery over the weekend. He was the ODT reporter who has given you most of the things that you've read about this hospital to date, and he died almost suddenly after that remarkable article in Saturday's paper, if you want to go back and have a look. I want to acknowledge Michael Woodhouse, who's a parliamentary colleague of mine in an earlier time, and except he's still there, and I'm not. And that'll do for opening remarks. So I'm just going to talk to a couple of slides. That one tells us that, I suppose the message from that slide, apart from the fact that it's a slightly interesting photograph, is that when we do come to demolition, and we'll see when demolition starts, but for the moment I'm going to announce that it's going to start, say, in the first week of March 2020. We won't see an awful lot of it, there won't be any dust in the first week or month or whatever, because there'll be people inside gently unscrewing and unbolting bits and pieces. But when that's a very big demolition job, all of the consents add up to a big task. There are probably 15 consents to be lodged and dealt with by the city. And when you can see from the photograph, when we dig down into especially the Cadbury's site, we're digging down into 150 years of industrial activity, and who knows what we will find. You can be sure there'll be asbestos and all of that, but who knows what else we will find. So one of the many uncertainties in this project is what's going to be under the ground. That'll do for that photograph, I think, don't you? Where are we? Yeah. So there are 5 stages of design in a hospital, typically. One of them is called master site planning, one of them is called concept design. And we are getting close to closing out concept design. We've run into some budgetary problems, which means that we have stopped to go back and redo and rejig and see whether we can move back into budget. That's the second time this has happened. It happened most recently about April of last year. It might happen again, I don't know. But just to let you know that we've got ourselves getting close to the second stage of a 5-stage design process. The third stage is rather unfortunately called preliminary design, so it does indicate to you that things are still very early, and one of the things that will happen tonight is that you'll, even as you might be questioning decisions that are already taken, you will mostly be finding that there are decisions that are just not taken, and so often our answers when we get to questions will be, sorry, we don't know. We'll try and add some information so that we can give you a bit more than just a blanket don't know. We've got a new design team actually has been signed on since that slide was written, and the ink on their contract is now dry, and so they will. I'm not in a position to announce them just yet, but we very soon will be, and they will be here for years. The health planners will be here for years. The architects will be here for years. The quantity surveyors, the engineers, the other engineers, as well as the other engineers, and they will become people that some of us will become quite familiar with, hopefully will become friends with. There's someone's put up the other stages there of construction, fit out and handover. This is a project which will run for another 9 years, we are thinking. So it's due to finish in November 2028. It's big. I think everybody knows that, but just let's get it said. It's the biggest hospital in New Zealand's history. And the reason that it's such a big hospital, given that Dunedin is not the biggest city, is that it is near enough a complete rebuild. It doesn't involve mental health, it doesn't involve oncology, it doesn't involve a few other things like orthotics, but it involves nearly everything else. And so that's unusual. Usually a hospital is an extra wing, another block for elective surgery, something for children's health or whatever it's to be. This is the whole shebang. And I'll answer a question now that I'm often asked, so that it's just a way of getting ahead of the game a little. People often say, what will happen to the existing hospital? And the formal answer is, it's out of scope. That is to say, we are not concerned about that. The new Dunedin Hospital isn't concerned about that. The DHB is, because it's their hospital. But that's not a very satisfactory answer, so I usually go on and give my personal opinion. Here it is. In my view, one of the two buildings, oh, that's a bit of a shame. I hope the rest of you have all turned your phone off. It's my wife telling me, it's my wife wanting to know, where is it? I don't know if anyone else has got my wife's phone number. They might like to help her answer that. But the clinical services block will, in my view, be demolished. That's my guess. It's too full of asbestos. It's too leaky. I don't think it'll be refurbished. I could be wrong. And on the other hand, I think the ward block has got a very significant life as a lot of things. Maybe as offices, maybe as part of a university setting, maybe a place where students live if they're very well behaved. So that's what I think will happen with the two buildings. Okay, so I've told you about the demolition contract, and the Wilson site acquisition is, let's consider it near enough done. It's not done till it's done, and we haven't announced it, so you're not allowed to draw too much from it. But we've got a bit of ongoing negotiation with solicitors in Singapore, and that'll be finished now or very, very soon. So that'll do for me, I think. You can take over from there, Chris.
Sure.
Thank you.
Rightio. So I'm going to talk about models of care, which is really whilst we're here about the Dunedin Hospital redevelopment. An often misstated comment about I think at an earlier session there was a statement that Dunedin Hospital will be 30% smaller. It's not. It's going to be bigger than the existing Dunedin Hospital, but what it will be smaller than if we just leave the models of care as they are currently operating, what we would have to build to be able to fit within the hospital. I'll just acknowledge my CE colleague from Wales South, Andrew Swanson-Dobbs, over there, and also the chair of the Clinical Community Health Council, Karen Brown, because one of the key planks of our strategy is about how do we develop models of care that mean you can have contemporary practice in terms of accessing health services in the community, which is when you need the majority of your health services, and then come to the hospital when you need those facilities to be available and the services to be there. So firstly, we developed the primary and community care strategy and action plan, and a couple of years ago we announced we were going to develop healthcare homes, we were going to develop locality networks, and we're going to develop community health hubs. We're really excited that the development and the working in partnership with the Primary Health Network, healthcare homes are now rolled out to a volume of GP practices right across our district. That means that 40% of us enrolled with GPs are enrolled in a practice with a healthcare home. That's providing more timely access to services and interactions within the system, and enabling primary care to do more, enabling care to be closer to home. The second thing is in terms of integration of primary and secondary services. I went and visited a practice some time ago, and they were quite proud when they told me about a room in the corner of their practice where a hospital specialist came and did stuff. I don't know if they could tell me who the name of the specialist or exactly how it was done, because it was kind of renting a room and patients turned up and disappeared, etc. Community health hubs are the focus about how do we integrate primary and secondary services in a way that is best utilising the skills and the expertise of health resources right across the continuum. And so we're having the conversation at the moment about how do we transform, how do we think about secondary care beyond the hospital setting, how do we enhance the use of technology. A little known snippet of information that one of our team gave me the other day was in the last year we have paid for 6 million kilometres of patients travelling to come to see us. 6 million, and that's only for the people who qualify for travel assistance. So the actual number will be a whole lot bigger. How do we enhance the use of telehealth and technology in terms of reducing the needs to be able to having to travel, particularly when you're talking about people from Central Otago, from Waitaki, etc. In the development of community health hubs, we're just having the conversations at the moment about saying how can we provide care within those hubs in an integrated way. And we're going to start by looking at what is a whole system model of care for 3 services that are quite regularly looked at right across the continuum, and so that's older person's health, child health and mental health. So what is the model of care that we want to have across our southern health system? And then from that we can then start to articulate, now how might some of that operate in a community health hub? What needs to be in a hospital? Because there will be very few services that will be entirely hospital based or entirely community based. There'll be some, we're probably not going to have an ICU in the community, but there's very few services that sit just within one. And so from that perspective, we're starting the process about service planning, focusing on what is the future direction of travel for how the services are going to develop over that time. And we've got a view towards wanting to have a picture of what a community health hub in Dunedin is going to look like by later this financial year, so towards the end of June next year, to be able to then start to move into the next stages. Plenty of interest in it, but the question is often asked is exactly what is it going to look like? And I think if we could do that individually, then we would be kidding ourselves. We need to have health providers, we need to have consumers involved in those conversations to make sure we get the best of both worlds. So what does that mean in terms of what does the conversations about models of care mean? We do need it to be operationally efficient. Unfortunately, often people say to me, just get the government to write out a bigger cheque for a bigger building. There is no free lunch. Borrowing money from the Crown or equity from the Crown, there is a cost to the DHB, there is a cost to the country of that. We need to make sure it's efficient, it's affordable, and that it's functional. And a lot of those issues are quite intertwined. The hospital will be bigger, but it will be smaller than what we would have to build if we just left the models of care going the way they are. But one of the exciting things, that happens within a modern development is that there's a whole lot of inefficient space in the existing Dunedin Hospital. It's not built for modern healthcare, so we can get more clinical space. We are challenging our thinking, and that is really challenging for staff and right across the continuum. And we're working between the DHB, the Ministry and clinicians to agree on a final option in terms of configuration for facilities moving in terms of the rebuild. I'm now going to pause. Yes, I am. I'm going to pause and ask Kathy to just pop up and talk about where we're heading from the perspective of the Commissioner team.
Thank you, Chris. The new Dunedin Hospital is a project which has been an integral part of the Commissioner team agenda since we were appointed in June 2015. as Chris has signalled, that physical space is long awaited and much needed to relieve pressure on the existing hospital facilities. And the project has also been a catalyst for engagement with both our clinicians and primary care as to the way in which care will be delivered in the future. But that project has also been part of the Commissioner team's focus to move the DHB to a position of sustainability. And so as the Commissioner team's term comes to an end, there is the opportunity to reflect on what has been achieved, the journey ahead, and the further opportunities. And that is what we have been doing with our communities throughout the district over the last fortnight. So back in 2015, as I'm sure you will recall, this DHB was under significant pressure. It was under significant financial pressure. It was under pressure in terms of its relationships across the district and with its key stakeholders. Those relationships were not strong. And although the DHB placed great value on its relationship with the Otago Medical School, in many areas our models of care were no longer contemporary or leading edge. We had become isolated. So of all of those challenges facing us, what has been the greatest? Well, it wasn't the financial challenge. We never saw financial stringency as a pathway to repositioning the DHB to a position of sustainability. The biggest challenge has been in finding ways to work together to maximise the district's healthcare resources. Graham Crombie, who until his death earlier this year was one of our deputy commissioners, liked to remind us that the footprint of Otago and Southland is twice that of Belgium. We are a small country in terms of geographical dimensions. So repositioning the delivery of healthcare in the lower part of the South Island cannot nor should not be undertaken by the DHB alone. It requires a joined-up approach rather than a series of silos, a network of health services to deliver better and more coordinated care. And so that network is made up of our rural trusts and hospitals, primary care, community care and community providers, our educational partners, the university and polytechnic and iwi. So we have focused on pulling those resources together in order to provide the care our communities need. So repositioning the delivery of healthcare services in Southern continues to require us to do things differently for a number of reasons, to address those challenges that I described, and in a context in which funding continues to be challenging. We also need to do things differently because of the increasing demand for healthcare services and our ageing population. The cohort of those of us aged 65 plus will increase significantly in the next 25 years. We are living longer, we're requiring more complex care, and so we cannot meet that growth in health need by simply doing more of what we presently do. We also know that there's variability in access to health services across our district. The closer you live to the location of subspecialty services, such as ophthalmology, urology, rheumatology, the more likely it is that you will be referred for care. And thresholds for access in relation to some services, particularly orthopaedics and general surgery, may differ as between Dunedin and Southland hospitals. So we need to ensure that your access to care is not determined by the part of the district within which you live. We also need to do things differently because of the tyranny of distance. Driving 3 hours to Dunedin or Southland Hospital for a 10-minute appointment. That impacts on your time, on the time of anyone who accompanies you or who drives you. You may have had to make arrangements for the care of children. So, how are we addressing this challenge of doing things differently? Well, as Chris has signalled, the partner for the planning associated with the new Dunedin Hospital is the focus on primary and community care, increasing the range of services that can be delivered in that context, with hospital care focused on the sickest of our patients who need acute resource-intensive care. There are other areas in which we know we simply need to do better. Our geographic footprint means we should have extensive use of telehealth, and we don't. We're also doing things differently by uncovering and addressing service challenges such as ophthalmology and urology. We've turned over stones and dealt with what has been revealed rather than putting the stone back. That has been challenging for our patients and for us. And in the context of many of those issues being long-standing. We've also addressed it and invested in physical facilities, the new ICU at Dunedin Hospital, the redeveloped ED at Lakes Hospital. We've established a community health council chaired by Karen, enabling the community voice to be heard in relation to major projects such as the new Dunedin Hospital, but also in relation to the redesign of services. So back in 2015, we did turn our mind to the question of, well, how would we know if we had been successful as December 2019 approached? If our goal was to reposition the DHB to a position of sustainability, what did sustainability mean? Well, it meant clinical sustainability. In the last 4 years, as I've signalled, we have turned over a lot of stones and endeavoured to address those challenges. It means sustainability as to quality, change that is clinically led and management enabled. It means sustainability as to our workforce. Our people are our most valued resource. And it also means financial sustainability, and our position has improved relative to the rest of the sector. So, coming back to our starting point, the focus on the new Dunedin Hospital is linked with many of the strategies I have shared with you. It is an integral part of the pathway forward for Southern. And perhaps, Pete, you might like to share more about the hospital.
Thanks very much, Kathy. So what we want to do is go to questions and comments. I could easily talk for another hour. It just wouldn't be the right thing to do. It's just important that you pick up the things, the bits and pieces that matter to you. If you want to ask a very vague, open-ended question, that's fine. There's no such thing as a silly question. You want to ask a particularly narrow, focused question, we probably won't give a good answer to it, but we'd happily receive it. So why don't we just have a pregnant pause? Oh, not for very long. There we go.
I'm concerned with the shortage of capital, the necessary, not desirable level of parking for patients, visitors and staff will not be provided. Can you tell us how many parks in those three categories are planned, please?
No. I can't. So car parking is not finalised, but our notes did say that car parking would be the first issue raised. So congratulations to whoever wrote the notes. There's a thing called the indicative business case, and then there's a thing called the detailed business case, and then there's a bunch of things called consents. The indicative business case went to the Cabinet 2.5 years ago, and that's the only document that has an indicative indication of how many car parks, and the number's 250. So the planning then that was signed off, just indicatively, hence the name, by the then Cabinet, the previous government, was 250 car parks. The current planning, the concept design, hasn't gotten to car parks yet. We're doing things like the number of ICU beds, the number of HDU beds, the number of surgical theatres of this, that or the other sort, what the front door will look like with ED beds and all that goes with it. That's where we're focusing, right on the core of the hospital, and trying to get those numbers right. And the reason that we're focusing on that and not on car parks is that that stuff is hard to increase later. It's not impossible, but it is hard to fix a hospital if you build it too small, nor do you want to build it too big. There are two reasons for not building a hospital too big. One is that you can't spend them, you've wasted money, and the other is that the thing becomes too cavernous and the walking distances become absurd. So we're trying to build a hospital that is big enough but is compact, and when we've done that, we'll think about car parks.
Probably a good point. There's a number of areas that have been articulated as being out of scope of the rebuild, and broader car parking. Something that my staff bring up is childcare facilities are outside of the scope of the rebuild. Everything that is out of scope of the rebuild, as chief exec for the DHB, I need to come up with a plan for. So. We have take childcare. We have obviously a female-dominated workforce, and we have lots of young. We want lots of young staff working for our organisation, and so therefore there needs to be readily available, accessible childcare services that don't open at 8 o'clock and close at 4:30. Given that our nurses start at 7 and our allied health professionals, etc. Likewise, in terms of where are our staff going to park, so that the parking doesn't all get gobbled up by our staff, and so everything that's out of scope, we have to find solutions for. But one of the things your comment of because there's not enough capital, $1.4 billion is the biggest amount of capital that has been invested in any DHB's infrastructure. And one of the sobering facts that I often like to share with staff. For every $10 million we spend on a building that is unnecessary, the cost of servicing that $10 million means that we can employ 10 less nurses, because the cost of paying for the $10 million per annum equates about to the cost of 10 nurses or of a similar ilk. And when I hear all the unmet need. We need to get that balance exactly right so we can be investing both in robust hospital services but equally in primary mental health and access in the community, etc.
Thinking about the workforce need, what work is being done with the likes of Ministry of Health, HRC and people like that, the funders of research, to actually make sure that the service plans and the ideas that are being created now are actually going to be fit for purpose?
Well, HRC funding, if you don't mind me saying, is a little distant from the centre of the hospital build. HRC funding for everyone is the Health Research Council, and the context of the question, I think, includes the idea that this hospital is being built next to a health sciences research intensive university. So it's not out of the park, but it is not the same thing as building a hospital. And certainly a lot of our planning, our master site planning, is to think about not who's going to fund the research, but where the research may be done, and should we have, the university's thinking about translational research facilities, and we're thinking about how we might interface with that. So that's certainly on our radar. But actually, if you don't mind me switching your question around, if you pick up the word workforce, my head goes immediately not to who's going to staff this hospital, but who's going to build it. And there we, in my view, face a very significant challenge indeed. There's a number of people in the room who have been working on this, including some people I've just been meeting with, so they may get up and make some remarks. It would be good if they did. But the short of it is this. that we're going to need around about 1,000 people for the 5 key or 4.5 peak years of the build, 4.5 of the next 9 years. Roughly 23, 4, 5, 6, or 24, 5, 6, 7. And right now we don't know where they're coming from. They're coming from a mixture of people who are in town now, people who are in town but or in the region or might return to the region who might need some training or a lot of training, and people that we will import as overseas labour, and that raises a question about where you house them. So there's a lot of thinking going on about that, which we can explore with if there's a further question. I'm sorry to turn it around on you, but that's my instinct.
Let me be a wee bit more specific, you hold on to that, don't worry, regarding your parking, because the DHB has a responsibility for the safety of their staff, and I refer particularly to your young female staff working late at night, often finishing shifts at up to 12 o'clock at night, starting at 10:30 at night, finishing at 7 in the morning. And I ask this specifically because I was asked to do a security review of the Christchurch Hospital some years ago by the Chief Executive, and I was appalled to find that many of the young nurses were frightened to go to work because there was no facilities for their security regarding parking. As a result of that, the hospital board in Christchurch took the initiative. They worked with the City Council and private investors and put up a parking building right beside the hospital. It was probably funded, I think, by private enterprise. The nurses paid for going into the hospital, but I believe that's part of your duty and responsibility as employers to look after your staff. And if you don't do it in your planning process, it'll never be done.
That's why where I articulated in terms of once we have clarity around the scale of parking that will be in there, absolutely the concept of what is the wider parking plan, and there's been conversations in terms of both university and the DHB have had some of those conversations about how can we come up with an integrated solution, and indeed the opportunity of other parties being involved in it. Yeah, absolutely. And that's when we, particularly also when we, there's a combination of both the wider parking but also how we use the parking that is on site. So at the moment, for example, the on-site parking at Dunedin Hospital in the daytime is designated for particular uses, and the night time is open for those very staff to be able to access and use. I often go to work in the morning and find someone in my car park because that is a nurse using it for the right reasons, and that's what we should deal with.
Would the mental health services be improved?
Well, look, one of the things
and also like an acute service, like say if someone has problems, and would they be able to go up to Wakui or have a small acute ward in Dunedin Public Hospital, the new rebuild?
There are emergency psych services in the rebuild plan.
Is it going to be better?
Pardon?
It's going to be better now?
Will it be better than what's there? Of course it will be.
Now?
But then secondly, mental health, the wider mental health redevelopment is excluded from the scope of the rebuild. But one of the things that we have committed to is you go to Wakari and you have a look at the facilities that are there.
It's pretty old, Wakari.
Absolutely.
Very
and
old.
so we're starting the process around a business case for that, which is separate but kind of related in terms of going, when we look at the facility master plan, when we do redevelop the mental health facilities, should we redevelop them at Wakari? Should we redevelop them, be co-located alongside the main hospital, etc.?
Along by the hospital too.
Pardon?
I might pay to have it by the hospital.
Yeah,
and all the time.
And look, I think there are some people that are...
And also, will there be buses going down for the new hospital, like the new one, like the one now? The buses going to appointments and back?
The shuttle. Look, the
normal buses.
Yeah. The concept of a future configuration of mental health is definitely on the front and centre, and we're working with the council around with our local advisory group about making sure that we're integrating transport planning. So that would be where the buses things. I think that lady there had her hand up first, and then yourself.
Right, okay.
Oh, sorry. Okay. Okay.
I've got something to say later.
Okay.
I don't need the microphone, I'm deaf. So what new technology will you be providing, and how will that help you to improve services at the new hospital? You know, what can you tell us about that? Do you have any details or any ideas at this stage?
It's not the first time this gentleman and I have had the conversation. Probably the smartest thing to do is to say in response to that question that this new hospital will be very digitally enabled, which means lots and lots of different things to different people. But given that this gentleman represents the view of the community of people with disabilities, technology can usefully improve access for those people, and this hospital will be equipped with a very large amount of fibre and Wi-Fi points, so that as the new technology comes available, the DHB has the option of installing it. Okay?
In the back there, and then the chap with the beanie on.
Just in regards to the demolition work, is it one contractor getting the whole contract, or you're starting with Cadbury's and then the other buildings? I work for a place that helps people find work, so I'm just wondering, is it...
Probably. I don't know. Do you know? So we don't know. Here's why. The contract has not been let. It will be let before Christmas. I think there was a short list of 6 or 8 bids. I don't know how many of those bids were a consortium of more than one firm. And I don't know whether the bids were for just part or all of the work. The work will be let in different lots, so there might be one group involved with the above ground stuff, one group below ground stuff, one group involved in dewatering, one person involved in detoxifying the soil, whatever it's to be. We don't know. And the reason that we don't know is that this is a Ministry of Health project. There's some Ministry of Health people in the room who may choose to answer. But we don't procure. In other words, it's done at arm's length from me anyway. And all I can tell you is that it is a pretty competitive process for which I am pleased. That is to say, it suits me that a lot of people want to be involved in this early stage of the build. It's a good indication of interest for later on when it is going to become a humongous job, and of course it keeps prices down, which I'm interested in.
Thanks very much. I have a very pragmatic, if boring question. In what will the building be clad, or if I may rephrase that, can you reassure us that the building will not be clad in a flammable material such as aluminium-clad polyethylene plastic?
Well, I assume so. I mean, we're not going to not learn that lesson, are we? It might be worth saying that, facade choice has not been made, rather obviously. We haven't even begun preliminary design, you might recall. But the building will be designed to high environmental sustainability standards. And I can't imagine that the thing that you've just mentioned, which is, I presume, the cause of the fire in London, I'm sorry?
The cause of the rapid spread.
All right.
It
So
doesn't-
I can't stand here and say that it won't be, but can you imagine us ever being that?
There are 2 buildings in town that are clad in the same stuff.
Yes, but they won't have been built since then, will they?
Am I allowed to ask, actually, how did you manage to choose the site
Yes.
without actually looking at asking the public and finding a better site?
Oh, really? So you
Yes,
don't
I
like the site?
actually feel that you need to be a block back, because you're talking about building a hospital where it's close to town, where people can go to town, and yet you're moving 8 businesses, taking them out of town, and taking away about 200 car parks plus the social development. All you had to do was take away 2 or 3 residential properties that the university has, rehouse them somewhere else, and use it just over the road there.
Just over the road where?
Just over the road where the hospital is at the moment.
You mean where Cumberland House is and Hayward House is?
Exactly where Queen Mary was.
Yeah.
That block. Why wasn't that block used where there's so much disruption with the other block?
Well, the DHB, including this gentleman here on my left, would say that it was a shame that the DHB ever sold the land. The DHB owned that land. It used to be the nurses' home, of course.
Yes, well that's, I mean, you don't own the other land, so acquiring land for a hospital is quite a different bill. You know.
Yes, I know.
Just go and knock on the door and say we want to buy your land.
The beginning of my answer to your question was the DHB regrets that it ever sold the land.
Okay.
Yeah.
Would it like to buy it back?
And then the difficulty of buying it back was that it would have disrupted the university's accommodation and therefore the heart of the Dunedin economy for a number of years, because a lot of students live there, and we would not have been able to get started there early enough to build a hospital early enough.
Not many students actually live in those 2 blocks.
About 450, is it?
Okay, so how many people work in that large block of 8 businesses that you are getting rid of, plus the social development, plus 200 car parks? How many people are you disrupting there, moving their businesses?
Well, we are.
And you're putting the students are in town 5 months. 5 months, and then they get a degree.
Well, I'm sorry that you're.
I know. I'm actually just wondering who chose it. Who chose that site?
Richard,
Richard, we just make the point that even if we had been able to choose that site, it was not sufficient in itself. We would have still needed another block alongside. So whether it was Cadbury's plus that block, or whether it was that site plus that block, we were still going to need more than one site. And just going back to the start of your question, what induced us to choose that site? Well, actually there was a huge amount of community input into that decision, actually, not in the sense of we had the city council pushing very strongly for a central city site. There was a huge amount of involvement in terms of social media and letters to the editor around where the hospital should be located. And whilst there were people, actually including myself, initially, who thought it would be more sensible to have it up at Wakaari, as it turned out, that wasn't going to be possible either. So it wasn't just a simple decision of saying, well, let's stick it there. And as I say, if we had been able to use that other site, we would have still been in two blocks.
The other thing that's important in the thinking, which is where Pete talked about the existing Dunedin Hospital site, a wise health service has a 100-year plan and goes, we're building these buildings here. When they get to their end of their life, where do you then go? And so that's really important that we get a sort of a strategic long-term think, so that we don't end up in exactly, I won't be in, I'm sure I won't be in my role when this hospital is at the end of its life, but that there's actually a long-term logic about how we utilise existing land to make sure that we've got a pathway that goes out long-term. The lady, with your hand up.
Just a comment about, for instance, the issue of cladding. I mean, I was in London at the time of the fire, and I can tell you it caused trauma throughout the whole city. And then all of us who were heading anywhere in that direction had the trauma of looking at this reminder, and it was pretty horrific. Now, so that leads on to a comment. One of the things that came out of that whole issue of cladding and a great many other issues, because there is always a cluster of issues, it's never just one thing, was a lack of oversight and, well, let's use the word supervision of decisions. So this is a huge project, and I understand there's a huge team involved, but what I know, is I've got a design degree, is that you can get so bound up in your own perspective of something that it's very hard to stand back occasionally and take an overview. And I want to know if that aspect has come to some sort of discussion and what might be done to sort of satisfy or at least reassure the community that that's being done, and that if there are significant issues that come up along the way of the project, they get proper attention and proper airing, and maybe the community can be involved rather than people say, oh, we don't want to involve them because they might get...
So I think to start with, the extent of the teams that are involved in the development provides an absolute assurance that this isn't in-house thinking. One of the challenges about hospital redevelopments in the past has been that it's been left to people like myself, chief executives of running health services, to also, it is not my, planning and designing new buildings is not my expertise. It's something that you do once, or maybe if you're lucky twice in your career. That's where the expertise at the ministry are contracting from a wide range of people. The comment about having just, not the DCC, but just having spent the last 3 months waiting for a permit to put a window in ED and Invercargill, in terms of all the fire regulations and the requirements there, I'm entirely confident that the extent of the scrutiny around consenting and the scrutiny around the use of these buildings will be such that those aspects will be there. The other thing is we are making sure that we are involving the community, both a combination of periodic forums like this, but also through the Community Health Council. And we have Community Health Council advisors on all of our groups, I think all of our groups, our FIT groups, most of them. Our FIT groups, which are facilities and transformation, they are people designing or planning around what is required for each of the respective departments. We've also recently been developing our disability strategy to ensure that how we're developing services and how we're developing facilities thinks about the issues associated with the need for the different users of our facilities within it. So there's plenty of opportunities of being involved in those processes. And if you do want to become a community health advisor, I'm sure you wave your hand, Karen. Karen's the chair of the Community Health Council. I'm sure if you touch base with her at the end of the meeting, she can point you in the right direction. Because one of the things that I've known and learnt in my experience in health, what I think is an important issue in terms of service planning, service development, etc., and what you think are quite likely to be different. And it's coming together that we end up getting the best result.
The one thing that I was wondering about was the physiotherapy pool. Is it going to be included?
There's no, I know of no threat, no current threat that I know of to that pool. There are no plans afoot that I'm aware of which would do that pool any good or any harm.
No, I mean in the new building.
We're not taking it into the new building.
Because, there are
It's staying
people
there.
that need the pool.
We're not putting a new physio pool in the new hospital. It's staying where it is.
And we're talking with the pool trust around giving them a greater degree of certainty, at least over the next decade, until we've done wider facility master planning in terms of what is the future use of those sites. But at the moment, that location is not a critical location for the hospital rebuild.
Thank you very much for the work that you are doing. It is a very big task, and so, you know, the work you're doing, I think we need to say thank you for that from a community perspective. Just thinking, you did mention a little bit about the future, and maybe it's the 100-year plan, but whatever it is, but what's the future looking like in terms of the new building site? Are you land banking, or is the actual building, I suppose, got capacity for, let's say, 20 years, 30 years before you have to think of whatever that might be, and who knows what health will be like then?
You know, I would say that we have probably, you could argue, probably bought too much land by a little bit. That is to say, when we've finished building this thing, we will still have some room for some things to happen. Some of that translational research that was hinted at in the question there. The new oncology building, which is not being built as part of this facility, but may be being built in the future. There's no good point in replacing that oncology building. It's built in 1993 or something. It's in relatively good shape. But when the LINACs, the linear accelerators, ought to be replaced, then we would think of putting in new bunkers across the road and building there, and there will be room to do that. It may be when we learn that as a separate initiative outside the scope of this, we may be making changes to mental health, and part of that may involve, for example, an acute ward in the central city area. There will be room for that. And then lastly, there's Chris's comment about 2080 and how we probably shouldn't have hocked off the nurses' home when we did, and how we ought to think about that again. And that means working closely with the university. In fact, the business school said to me last week that they will happily do a study for us on how to get that sort of 60-year plan that Chris thinks of. We haven't engaged them, but the offer's there, so we might.
In the back there, then we'll come to you.
This is probably not a question for right now with your planning, but I've been with an elderly relative quite a lot recently to your ED department. They keep having falls, and I've often thought they should have elderly people in a separate area from the general ED. Do any hospitals do that? Because a lot of the time, and the people that I saw in there were elderly people that probably wasn't emergency.
There's multiple challenges to that question. Firstly, no, I'm not aware of any hospital having a separate elderly ED. They do, bigger centres will have a separate paediatric emergency department. But a couple of the challenges is, one of the things that I think in terms of challenging our models of care is, why is the front door always ED? So, you know, if there's a patient in a practice that needs an admission, why can't there be direct admission? And some of the activities that we're working on at the moment are really challenging that. And then thirdly is, do they really need to be coming to the hospital, or if there's while we're getting the whole system model of care for older person's health, is that some of those less acute activities could be provided in a different way. Yeah, and then I've worked in other areas where there's been protocols for agreed pathways where actually the ambulance can take you somewhere else. Okay, but it has to be set up in that way, and it has to be configured and ready. So, yeah. Then there was this lady. Yeah.
My questions are we going to be able to have a helicopter pad on the roof of the new building?
Yes.
Definitely? Perfect.
You wouldn't build a hospital of this scale in today's world and not have it.
Yeah, hi there. I guess I'm just a bit concerned about what the impact will be on the railway station and that sort of like tourism quarter of Dunedin, and maybe how it will blend in with that. Are there different things we can think of in terms of what a hospital actually is? For example, like Riverside Market in Christchurch, where they've, you know, because you've got a whole a wall or a street that faces one of Dunedin's jewels, really.
Yeah.
So I just wonder if there's anything going into design that's looking into that
Yeah.
that sort of aspect. Make some money for the hospital too, selling food or, you know, something to help us be sustainable.
Yeah, so we are acutely aware of where the big building is likely to go, and as we argue, debate, discuss, contest where it sits on the site, to what extent it flops over St Andrew Street, etc., and there's now a new set of debates arising around that because we've been able to take some square footage out or square meterage out. All of the while, this is in the context of the hospital being a very large building just to the north of the most photographed landmark in New Zealand, second most in the southern hemisphere after the Sydney Opera House. We won't get a consent if we don't get that right, nor should we. We have done, as you would expect, a lot of studies on shadowing of one building on the other, so not just the building, the hospital on, say, the railway station, but of one building on the other. And we have also undertaken to preserve a thing called the Dairy Building, which is a little bit of Cadbury's, which has a frontispiece onto Castle Street, and you'll notice it there because it's just been tarted up, or half tarted up, by the departing Cadbury's, and will become the property of the Southern DHB. It is the property of the Ministry of Health, be made over to the DHB when it's all finished. So we are very thoughtful about that, and I hope that you will agree that when you see what we've come up with, I mean, we're going to be building, it's a big building. It's huge. It's the biggest building ever in Dunedin, easily. So we have to be careful with it.
Barbara.
Are there going to be any green spaces, please? Green.
Not many.
Thank you.
There will be some. We will, I'm sure, it's for an architect to answer, there will be some indentations in the way that, you know, in the streetscape, there will be entrance ways, and you've heard me say that there may be initially some unused land while we wait for the oncology centre, for example, to run its life. But the reason I said not many is that it is a central city hospital. It is not on the edge of town, and so we can't accord ourselves a lot of green space for that reason.
The current hospital has a great deal of trees around it.
Well, if you think that's a great deal, then we won't disappoint you after all. Compared with Whakari, it's
yeah, and from a pure selfish health perspective, I heard that lady say should have been at Carisbrook. Well, I think you might have said. That's what you said. Absolutely, if you're entirely only focusing on a hospital setting, you would have a different shape. It wouldn't be in the CBD. But we're not dealing with just a hospital setting. We're dealing with the fact that in Dunedin, health and education are so intrinsically entwined. I would hope that there would be at least as much, because I'm with Pete. I think the amount of green space at the current Dunedin Hospital is appalling. compared to what I'm used to, but compared to what's here, it's a whole lot. There's a bit. So there should be at least that within the planning.
Is universal design part of the planning and design at the moment? Are planners and architects have some expertise?
I can't actually because
we're peering behind you.
Yeah. So look, the reason I was just I was about to turn to get an architect to answer the question because the term universal design is something that might mean different things to different people in the audience, and for you, I think what it means is that it is something that is something that you are able to navigate, that any of us is able to navigate irrespective of any disabilities which we have or don't have. And if you think of the range of things that people might come to a hospital with because they are blind or they're deaf or they're neurodiverse or whatever it may be, universal design is intended to accommodate those people. That's the essence of the question. I think the answer, I think the answer is when we sit down with our architects and we say, what are your design principles? I think they will say, yes, you would not build a modern hospital without its ability to accommodate the various things that a diverse population will throw at it. So, I mean, I just am not saying yes uncomplicatedly because we haven't found out yet. We haven't begun preliminary design, but it would certainly be, I would need a very good reason to not have universal design through this hospital.
And then we'll come over to the lady in blue.
Thank you for that. I'd just like to add a comment to the universal design. A very simple definition of is that it can be used by most people all of the time, which goes against accessible design, which is part of what you've described. And the other thing, quite a lot of stuff about accessible design is people think that it's ugly, and it is a key principle that should be involved, and it's for everybody, and we would really like to know a bit more about that down the track, please.
Sure.
On that, where should we part of design of the hospital?
And that's where the community health advisors are feeding in as a part of that process.
You spoke about a large building, and I was wondering if you've given any thought to a rooftop garden or something like that.
I have actually, but I haven't mentioned it with anybody. There's one thing I'd like to say, and that is that the designs that I've seen so far, you can't particularly see it in that drawing, have an awful lot of ventilation coming out, and I just don't know how much room's going to be around for a rooftop garden, but it would be nice, wouldn't it? I would like to think it could be done without it being too costly. Of course, as soon as you start putting weight on top of something, you've got to support it with steel. So we've got to be a bit thoughtful about it, but it would be nice. The other question that I often get asked is, would there be wind turbines on the top? And the answer's certainly got to be no. So don't run that one.
Helicopters can't land with wind turbines.
That's right.
Sorry, could I just make one other brief comment? I understand that breastfeeding has been brought up in previous meetings. I haven't been at them, I'm sorry. But you are going to cater for breastfeeding staff and breastfeeding mothers?
Too right. And we unfortunately, we have a temporary solution at the moment at Dunedin Hospital, which for criticality of needs we need to move again because that's where we have to expand the emergency department into. But part of the relocating it is finding an alternative location, which we already have. I believe it's going to be upstairs on the mezzanine in the cafeteria, but built into something up there, and in terms of the new development, those things are clearly a part of the design process.
Will the DHB be retaining ownership of the existing hospital site?
I'm sure there will be discussions and debates the DHB will have with the ministry over time, and it comes back to the wisdom of what do you hold on to versus what do you dispose of. And I'm sure whoever sold Cumberland and Hayward probably thought they got a pretty penny at the time, but it would cost way more to get it back now. And the other part is, if you think out to 2080, which is a sort of time period when you'll probably be thinking about replacing the hospital again, you don't want just a bit of land sitting in the middle of town not doing anything. And so what do you use that space for? If we do retain it, how do you generate some opportunities in terms of using the space over that time period whilst still being able to secure it in 2080 when it's there? But it will come down to some of those practicalities.
Hi. Firstly, a comment. I am on a fit group, and have been involved in consultation in the process. And none of the questions I've heard tonight, I haven't heard in meetings at the hospital, around the table, with the project team, with the planners, with the architects, the parking, the green space, the light, the shadows. Part of what our role is as community people is to bring those things to the table, and it's actually really reassuring to me that we're getting those questions and they're the ones that we're bringing to the table. So to the team who are doing it all, what more can we be doing as a community to help you guys get this right?
Well, excuse the random act of praise here, but thank you for doing what you do. And if there are other fit group members or people involved in consultation processes or people who want to become involved in consultation processes, thank you too. It involves reading papers, it involves travel, finding a park, it involves a bunch of meeting time and some thinking and compromise and putting up with half answers, and that's my life too, you know. So thank you. Yeah. Your question is what else can we do? And I mean, I would like to think that our consultation structures are quite good. There are, I mean, are there 50? How many groups are there? 53 or something? There are. We've amalgamated some into things called superfit groups, which is a bit of an unfortunate term, but there are groups for Africa, and so you know that feels to me like we are probably taking pretty good soundings, and all I would say was, when you say what else can we do, just remember where we're at. We've got a long way to go yet before we build, before we start building. So my answer to you is keep it up. Thank you.
The lady in the back, and then I'll come to you. Yes.
Just a quick question on traffic management around the site. We have a business in St Andrew Street, which backs onto Bow Lane, and we're concerned that the traffic going through Bow Lane or St Andrew Street will disrupt. I know there are other businesses around the area as well, but yeah.
Yeah, no, I think you should be concerned. I think the period of construction will be disruptive. I'm sorry to be just giving you that answer, but to say that it wouldn't be is not credible. And what's more, we've got to do some thinking as a city about whether or not we're going to leave the one-way system as it is, to the extent that, or whether we should change it, whether we should quieten one-way north, or whether that would cause great disruption and increased travel times. These are discussions that we will need as a community, and we will need them next year. So we're going to be thinking about that stuff quite a lot, and the people who are running that discussion are the New Zealand Transport Agency and the city, the DCC, with some help from the Otago Regional Council, who are responsible for passenger transport, and some of the thinking, in fact quite a lot of it, is starting to think around what more use can we use of the Strathallan Street part of town, and you can start thinking about that and people moving north and south more through that area, and we need to be thoughtful too about what further changes Port Otago might make in contributing to that. So there's all of that in front of us. Two things therefore. One is the long-term arterial routes in our city, and whether they stay the same or whether they change, and the second is disruption during construction. All I can say about the latter is that we have enough land for lay-down areas, so we do have an ability to bring stuff to the site and have room to leave it and just shift it when we need to by cranes, and that means that we're not always needing to bring trucks in and load off trucks. That sounds a bit twee, I know, but you don't want a whole lot of trucks standing in the middle of State Highway 1 all the time. And the last thing to say is that the big employers of Dunedin, which are mainly public sector, have just begun thinking around what they might do to improve traffic demand management. They are talking about partially pedestrianising the main street. That's a separate initiative, but one that we're well familiar with. You seem to be dismissive of that, but it's coming.
Yeah. In Bow Lane, there is a one-man business, and the only access he has to his business is on Bow Lane. So if that lane is going to be closed or whatever, then that's the end of his business.
I'm not aware of any plans for a stopple on Bow Lane at all.
That's the reassurance that I was looking for.
I think it's being used more as a rat lane, for rat running, don't you? Yeah.
Just going a wee bit back to what more can we do? Just going a wee bit back into what more can we do comment, and I'm just commenting about your communications department communications could be a bit more inclusive in terms of translated to New Zealand Sign Language, providing easy read, in terms of consultations and information provided, for example, on the website. Or
do you find the website useful?
It is a really good general hub for information, so it's useful to share the link, for example.
So both Nicola's over there and Ryan's the comms person dedicated to the project over there, and Nicola's the exec director of communications. So you guys can reflect on that. Yep.
And we do know that we put up some videos without signing, but on the other hand, this video is going up and it's going to be signed throughout, as you can tell. Very hard-working person to my right.
Bob, you wanted to ask a question?
Hi, I'm on the Community Health Council as as a logistics advisor, and the whole question of parking and transportation, pedestrianisation is a very big one on the menu. The photo that you have up at the moment shows a lot of people in the vicinity of the hospital. Now I know that's only a drawing for the sake of it, and there's a lot of work to be done, and I accept that at the moment the interior of the hospital and how it's going to be laid out is very, very important and should take pride of place. but people have to get to the hospital. And on one side of the hospital along Cumberland Street, you've got 2 supermarkets. And knowing New Zealanders, 1 or 2 of them might decide to cross the road from the hospital to the supermarket during the day. And then you've got the large car parking area at the bottom of St Andrews Street by the railway station, which could be made higher to take more cars. And then you've got the bus hub at the other end of St Andrews Street. And at the other end of Cumberland Street, sorry to do this, you've got the physio pool, you've got the medical school, and you've got the university. And therefore, as the Community Health Council, we've submitted a paper, which I hope you have seen, and if you haven't, you'll look for it, and determine whether or not it's possible to separate pedestrians from traffic. And the best way of doing that, we believe, is by doing aerial walkways from the car park down by the railway station to the bus hub and along Cumberland Street all the way. Now those can be made green areas. They're up above the traffic. There's no impediment for people with disabilities going anywhere. And you could even put moving walkways in there if you wanted to. But I'm just suggesting that when you are talking about the hospital rebuild, that I know you'll think very carefully about how people are going to get to that hospital, and that will actually feature into the design of the hospital, I would like to think. So if that is any of assistance for the future, thank you.
Make sure you engage in the consultation that the city and NZTA.
Well, I was considering that NZTA, ORC and the DCC should pay for that walkway, not the hospital.
We've been given a 5-minute call. Well, we didn't use it.
Just an alternative perspective on your green things. When I'm lying in bed with tubes sticking out of me, I'm not greatly concerned about green spaces, and if it costs money and takes space, I'd far rather that the money was put towards doing another hip operation for my mother or something like that. So just if I want a green space, I'll whip down to the gardens.
That guy hasn't asked a question. No, that guy at the back hasn't asked a question.
Yeah, you.
It's disappointing to know that the oncology won't be included in the new rebuild, but I haven't seen or heard much about the meals. Are they still going to be produced in Auckland and transported down by road, or are they going to have a facility in the hospital to make their own?
There will be a kitchen in Dunedin. Whether it's used or not will depend on the DHB, the board of the day, as to who they're going to. We will provide kitchen facilities in Dunedin, not in Auckland, and then the DHB will decide whether they're going to use them. There's roughly where the land lies on that. We can't say to the DHB, we're building kitchen facilities and you will use them. We'll just see.
What about a gift shop?
What about a what?
There's retail space in the facility.
There's a bit of retail space in the hospital, not much.
And I think the comment about the meals kind of comes back to the chap who talked about the green space. It is one of the conversations that, from a community, particularly engaging with Community Health Council, was about how we prioritise where we spend. And it is a trade-off in terms of we can spend. Pardon? No, but we can spend more money on doing this and less money on doing that, and we do need to get that balance in the trade-off. And I would rather that we are increasing access to health services in terms of as the first and foremost, but whilst at the same time making sure we're providing meals, etc., that are of an adequate nutritional value.
Thank you for coming.
No, I'm saying that we have to have that conversation and that discussion and the trade-off. And so if I said to the wider community, what shall we spend the next $1 million on? Shall we? I think yeah.
Yeah. So we're building a hospital. We've got a hospital building meeting here. We haven't got a hospital running meeting here. And thank you everybody for coming, and thanks for your interest. Thank you.